Reabsorption of sodium in proximal converter tubule. Almost 67% of the sodium is reabsorbed in PCT. The process of sodium reabsorption in PCT is isoosmotic. That is, the reabsorption of sodium and water are exactly proportional. The mechanism of sodium reabsorption early proximal tubule and late proximal tubule is different. In the early proximal tubule, sodium reabsorption has three steps process. The first step is transport of sodium from tubular lumen into tubular cells. Sodium is transported from tubular lumen into tubular cell by unidirectional sodium transport, that is symport, that where sodium moves out of the tubular lumen along with the glucose, and also with other solutes like amino acids, phosphates, lactates through the apical membrane of the tubule. Then it can also be with a sodium hydrogen exchange, which is the antiport here. Sodium is reabsorbed in exchange with H plus ion, and sodium hydrogen antiporter couples the entry of sodium with exclusion of H plus ion from the cell, and H plus secretion results in reabsorption of the bicarbonates as well. Then the transport of sodium from tubular cell into the interstitial fluid and to the lateral intercellular spaces. The most of the sodium are actively pumped into the lateral intercellular spaces by sodium-potassium ATPase. The rest of the sodium are pumped into the interstitial fluid by sodium-potassium pump situated in the basal part of the cell membrane. Note that small amount of sodium re-enters the tubular lumen by passive transport through the tight junctions. Transport from interstitial fluid and lateral intercellular spaces into peritubular capillaries. From the lateral intercellular spaces and interstitial fluid, sodium enters peritubular capillaries by concentration gradient. So this is the diagram showing the absorption of the sodium from the apical membrane. It can occur by two processes. One is with the sodium symport with glucose or amino acids or phosphates or lactates, and second one is it can occur with exchange with the hydrogen ions, where sodium is reabsorbed and H plus ion is secreted, and so this is going to also help in the reabsorption of the carbonates. Then when the sodium enters inside the cell, then it reaches the interstitium or lateral spaces mainly by the sodium potassium active pumps. So most of it occurs by the sodium potassium pump which are present in the in the paracellular area, and some of the it occurs from the basal part of the cell. Then from the interstitium and from the lateral intercellular space, so by passive diffusion it is going to enter into the capillaries. In late proximal tubule, in the second half the proximal tubule, sodium mainly reabsorbed with the chloride across both transcellular and paracellular pathways. In paracellular pathways, sodium is primarily reabsorbed with the chloride rather than organic solutes or bicarbonate as the accompanying anion, because the sodium transport mechanism in the second half of the proximal tubule differ from those in the first half. Furthermore, tubular fluid that enters the second half contains very little glucose and amino acids, but the high concentration of chloride, that is, it is around 140 milliequivalents per liter in tubule fluid exceeds the that in the first half, that is around 105 milliequivalents per liter. The high chloride is due to the preferential reabsorption of sodium with bicarbonate and organic solutes in the first half of the proximal tubule. This concentration gradient favors the diffusion of chloride from the tubular lumen across the tight junction into lateral intercellular space. Movement of the negatively charged chloride results in the tubular fluid becoming positively charged relative to the blood. The transcellular pathways, sodium and chloride enter the cell across the apical membrane via operation of parallel sodium hydrogen chloride anion antiporters. The secreted H plus ions and anion combine in the tubular fluid to form H plus anion complex that can recycle across the plasma membrane. Accumulation of the H plus anion complex in the tubular fluid establishes the H plus ion concentration gradient that favors the H plus anion recycling across the apical membrane to enter into the cell. Inside the cell, H plus and anion dissociate and recycle back across the apical membrane. The net result is uptake of sodium chloride in the apical membrane. The anion may be the hydroxide ions of formates, oxalates or bicarbonates or sulfates. So this is a diagram showing the sodium reabsorption in the late PCT, where the sodium is mainly reabsorbed with exchange with hydrogen ion, and this hydrogen ion make a complex with anion, and it is going to create a concentration gradient which can be easily recycled, and so this gets dissociated, and anion is antiported with chloride ions, and thus the net effect will be there will be absorption of the sodium with the chloride. In the loop of Henle, 25% of the sodium is reabsorbed. Ascending limb is permeable to solutes and impermeable to water. Descending limb is permeable to water and impermeable to solutes. When the filtrate enters the loop, it is isotonic, but in the descending limb, water is reabsorbed, thus filtrate becomes hypotonic. In the ascending limb, it becomes hypotonic. Here, sodium, potassium, 2-chloride are reabsorbed into the tubular cells by sodium potassium 2-chloride transporter. From the cell, sodium is reabsorbed into peritubular capillaries by sodium potassium pump. One potassium, one chloride are co-transported out of the cell. Another chloride passes out passively by diffusion. The other potassium is secreted back into the lumen. And this is going to how the sodium is reabsorbed from the loop of Henle. That is, it is mainly reabsorbed from the sodium potassium 2-chloride pump with the exchange, with the 2-chloride ions. And whatever the reabsorbed sodium, it will be pumped into the capillary by the sodium potassium pump. And sodium hydrogen antiport in the apical membrane also mediates sodium reabsorption as well as H plus secretion. Paracellular passive reabsorption of sodium, potassium, calcium and magnesium also occurs in the thick ascending loop. Note that because of the thick ascending loop does not reabsorb water, reabsorption of sodium chloride and other solutes reduces the osmolarity to 150 milliosmoles per liter. Thus, because of the thick ascending limb produces a fluid that is dilute relative to plasma. The ascending limb of Henle's loop is called as diluting segment. In DCT and collecting duct, the 5% of the reabsorption occurs in DCT and 3% of reabsorption in the collecting duct. In the early part of the DCT, entry of sodium chloride into the cell across the apical membrane is mediated by sodium chloride symporter. Sodium leaves the cell via action of sodium potassium ATPase, and chloride leaves the cells by diffusion through the chloride channels. In the late part of the DCT and collecting duct, the reabsorption is via epithelial sodium channels under the influence of hormone aldosterone. If you see the sodium chloride transport along the nephron, in the proximal tubule, almost 67% is reabsorbed. It is through sodium hydrogen antiporter, sodium symporter with amino acids and with other organic solids, and in the some amount sodium potassium 2-chloride channel antiporter. And in the loop of Henle, almost 25% is reabsorbed. It is mainly through sodium potassium 2-chloride symporter, where in the distal tubule 5% it is mainly with sodium chloride symporter, and in the collecting duct it is 3% is reabsorbed. It is mainly the sodium epithelial channels. Bartter syndrome, it is autosomal recessive genetic disorder characterized by hypokalemia, metabolic alkalosis, and hyperaldosteronism. Inactivating mutations in the gene coding for sodium potassium chloride symporter, the apical potassium channel or basolateral chloride channel decrease both NaCl and potassium reabsorption by thick ascending limb, which in turn causes hypokalemia and a decrease in ECF volume. The fall in ECF volume stimulates renin and aldosterone secretion, which in turn stimulates sodium reabsorption and H+ secretion by distal tubule and collecting duct. Liddle syndrome. It is a genetic disorder characterized by an increase in blood pressure secondary to increase in ECF volume. Liddle syndrome is caused by activating mutations in either B or G subunit of epithelial sodium channel, so which is composed of 3 subunits, that is alpha, beta, and gamma. These mutations increase the number of sodium channels in the apical cell membrane of P cells, and thereby the amount of sodium reabsorbed by each channel. In Liddle syndrome, the rate of renal reabsorption is inappropriately high, which leads to an increase in ECF volume and hypertension. The factors which are affecting sodium reabsorption, that is the hydrostatic pressure in the peritubular capillaries. Increased hydrostatic pressure, it is going to oppose the reabsorption, and it is influenced by the arterial pressure and the resistances of the afferent and efferent arterioles. If there is decreased resistance in the afferent arteriole, the capillary pressure is going to increase. If the resistance decreases in efferent arteriole, the pericapillary pressure is going to increase. Increasing the arterial pressure increases the peritubular capillary pressure. Normally, it is around 10 mm of mercury and favors the reabsorption. The colloidal osmotic pressure in the peritubular capillary, it increased pressure favors the reabsorption, and it is influenced by arterial plasma colloidal osmotic pressure and filtration fraction. Okay, so if the PC increases, there will be increase in the reabsorption oncotic pressure. And if the colloidal osmotic pressure increases, the pressure is also going to increase. If filtration fraction increases, the peritubular capillary pressure is going to also increase. Sodium intake, more the sodium intake, less the sodium reabsorption, and it also depends on peritubular capillary filtration coefficient, and it's a measure of permeability and surface area of the capillaries. So increase in KF raises the reabsorption. Then GFR influences sodium reabsorption by two mechanisms. One is tubulo-glomerular feedback and glomerulo-tubular balance. An increase in GFR causes an increase in the reabsorption of solutes and consequently the water, primarily in the PCT. So that in general, the tubule tends to reabsorb a constant fraction of amount filtered rather than constant amount. So this is called as glomerulotubular balance. Then we have sympathetic stimulation. Activation of sympathetic nervous system can increase sodium reabsorption. Then we have hormones like aldosterone, angiotensin II. Aldosterone increases the sodium reabsorption and potassium secretion by stimulating sodium-potassium ATPase pump on the basolateral side of the collecting duct and promoting the opening of epithelial sodium channels. Site of action is collecting duct and distal part of the DCT. Angiotensin increases the sodium reabsorption by three main effects. It is going to stimulate aldosterone secretion, and it constricts the efferent arterioles so that the capillary pressure decreases. peritubular capillary pressure. Directly, it is going to stimulate reabsorption of the sodium reabsorption in the PCT loop of Henle, distal converted tubule, and in collecting duct. Then the atyl natriuretic peptide decreases the sodium chloride and water reabsorption, whereas prostaglandin decreases the sodium reabsorption. Endothelin and interleukin 1 increase the production of prostaglandin E2, and they are going to decrease the sodium reabsorption. Then OBEN inhibits sodium potassium ATPase and decrease sodium